Good morning, everybody. Thank you for joining us for the global state of fatty liver diseases. My name is Dr. Sharon Jaycox, and I am the director here at Global Liver Institute for Fatty Liver Diseases. Thank you for joining us. Let me introduce you to our panel. We have a great panel of speakers here. We're honored to have them. We'll start with Dr. Quentin Anisty. He is a professor of experimental hepatology at Newcastle University. He specializes in hepatology, gastroenterology, and his focus area is MASLD, liver fibrosis, and metabolic liver disease. Then I'll go to Professor William Elazari. He is a professor of hepatology, director of research at Queen Mary University of London and Blizzard Institute. His specialty is hepatology, gastroenterology, and his focus area is NAFLD, MASLD, inflammation, and fibrosis, gut-liver axis. Welcome, Professor. We're going to go to Mazen Noureddin. He's a medical director at Research Institute. His specialty is hepatology. His focus area is MASLD, MASH, and he works in non-invasive diagnostics and clinical trials. And then we're going to go to Dr. Saima Ajaz. Dr. Ajaz, specialty is hepatology, works in lifestyle medicine. She's the lead of public and patient involvement engagement at the Institute of Liver Studies and at the King's College. She's an honorary senior clinical lecturer, School of Immunology, and specialty is mitochondrial biology, metabolic diseases, focus area on mitochondria dysfunction and liver diseases and energy metabolism. We also have Dr. Alicia Honore Felix. She specializes in lifestyle medicine. Her focus area is obesity, metabolic health, liver disease prevention. And then we have, last but not least, Rochelle, Dr. Rochelle Corrado. Is at internist and obesity medicine specialist at Revolution Medicine, Health and Fitness in Washington, D.C., with a specialty of internal medicine and obesity medicine. Thank you and welcome, panelists. So, really, we're talking today about liver disease. Liver disease is a growing global health concern. It contributes to approximately 2 million deaths annually, accounting for 4% of global mortality. The burden is increasing due to factors like rising obesity, rates of alcohol consumption, and viral hepatitis, which affects over 360 million people worldwide. So let's talk about it. Let's break it down. So, and I'm going to just kind of shoot this out there to the panelists, and anybody feel free to answer this. So how has understanding fatty liver disease evolved over the past few years? What are your biggest takeaway from the recent guidelines and research and clinical practices?
I think this is a really exciting time in the MASLD space. So if I look back to when I first started doing research in this area back in 2003, we had no good diagnostics, we had no licensed therapeutics, and we actually had a fairly tenuous understanding of the pathophysiology of the disease. Compare that to today, where we have the first drug licensed in the United States. There are likely to be other agents getting licensed by the FDA in the near future. We have tractable non-invasive diagnostics. And in terms of our basic science and our understanding of the pathophysiology, things have moved on dramatically in that time. So I guess 2025 is a great place to be from the point of view of MASLD.
I was going to say, as a practicing physician in the Caribbean, particularly in St. Lucia and Dominica, I've seen firsthand how the reclassification of NAFLD to MASLD and MASH has brought so much needed clarity to the metabolic drivers of fatty liver disease. The metabolic underpinnings like insulin resistance, central adiposity, and dyslipidemia and now the front and center of treatment here in the Caribbean. And this has helped connect fatty liver disease with a broader syndemic of cardiometabolic disorders. Now, when we talk about in terms of research and clinical practice and recent guidelines, we see that global guidelines at present, they are emphasizing earlier screening in higher risk populations, such as those with type 2 diabetes, obesity, hypertension, groups that make up the majority of my patients and patients in general for all physicians. And then we've also seen a shift towards using simpler, non-invasive scoring tools such as the IFB4 and the NAFLD fibrosis score, which have been particularly helpful in resource-limited settings like ours, where access to imaging is inconsistent in the Caribbean.
That's awesome. Professor Alawazi, were you going to say something regarding this issue as well?
Well, so no, I just want to, echo what has been said in terms of how exciting it is where we are now. I think, the idea that we were going to look at patients who had metabolic risk as a core tenet of hepatology practice 10 years ago even was for the birds, really. We were a specialty concerned primarily with cirrhosis, with end-stage liver disease, with transplantation and cancer, and driven largely by viral hepatitis. Now, I think we have a long way to go in all of those areas, but what has really become clear is that for those patients who have got metabolic dysfunction associated with liver disease, that they now have, exactly as Quentin says, a research body of researchers working on their behalf, trying to understand more about their disease, and pathways in place to try and find them, reduce the stigma, and ultimately to treat and prevent those end-stage problems. So I think it's the attention to MASLD, as giving it its new name, the attention to MASLD, I think has led to significant advances to our patients, even before the drug cupboard is opened most of the places in the world.
So what are some of the most significant advances in non-invasive technologies or diagnosis? Are these tools really readily being adopted globally?
I'll pick up on that. That's right. I think the answer is that the advances were made in discovering them. And I think it was fairly groundbreaking that you could take the idea that you don't need to do a liver biopsy and that the key prognostic feature could be approximated to a non-invasive tool. However, what we found initially was that these tools simply weren't being used. And what's happened in the last 5 years, and you can already start to see that, is that people in specialties outside of liver medicine have adopted the risk stratification tools, whether it's scoring-based, blood test-based, imaging-based. We can discuss those perhaps as the discussion goes on. But we've gone from, isn't it amazing that we can do this, to it's now imperative that we embed these in existing and novel care pathways.
Mm-hmm.
Yeah, I'd agree with you, Will. I think the other thing that's really come along, and it's even more fundamental than the advent of non-invasive tests, is just the recognition of the risk. So the simple fact that our colleagues in primary care and specialists in many fields in hospital medicine as well are aware that the presence of obesity, diabetes, hypertension, dyslipidemia, count them off on your fingers. Once you get to one or two of those, that is somebody you need to be questioning whether they have MASLD, whether they have SLD, depending on other lifestyle factors. And I think driving that message out is essential here. The next step is about the non-invasive triage and risk assessment, but it's almost an ancillary point. Exactly as Will was saying there are some very good tools. Some of them are incredibly cheap. FIB4 score, a very high negative predictive value. It's certainly not perfect, don't get me wrong, but it has a great deal of utility. And the important thing is, because it's cheap, you can repeat it a year later and a year later after that. And the key thing is that even if you do have some false negatives, the fact that it can be easily repeated vastly improves the sensitivity in what is actually a fairly slowly progressive disease for most patients. So, take that, follow on with tests, and there are a range of second-line tests. Some of them are elastography-based, some of them blood-based biomarkers, and we have a very tractable tool to help us identify the people we need to focus care on.
So I wouldn't I couldn't agree more with the rest of the colleagues. I think the most interesting thing in the last, what I have observed is the raising awareness. I think with the change in the definition of the metabolic associated steatotic liver disease, because it has now surrounded, it has encompassed the metabolic cardiometabolic syndrome. So now people are more aware. We've already had a lot of investment in the diabetes and hypertension and all these issues. Now with the definition encompassing all these things, I think the primary care and the pathways will be much, much more streamlined. I think and with the first drug being approved and with the novel biomarkers, I think that's what will be changing. There are a lot of things that we need to do. And I think one of the most important thing is raising awareness in the general population, because when you use the term, there's still a lot of unawareness, but yes, it's all in the positive direction.
I think speaking in the United States in particular, there's, I think certainly there's more education in terms of obesity and understanding the risk factors associated with it, including MASLD. But still, I think in America, there was a recent study that just came out looking at, the knowledge about MASLD itself was pretty low amongst Americans and even amongst primary care doctors. So about 50% of primary care doctors actually knew about the name change and knew kind of the diagnostic criteria and so forth. So I still think it's super exciting, and we have a lot of, movement behind this push, but I think there's still lots of educational efforts that need to go forth and carry on, especially for primary care, because they're kind of at the forefront of identifying and hopefully diagnosing people and determining and triaging who should go to see specialists. And there's still a lot of work to be done there. And there are novel ways that we can help kind of support them in doing that as well.
So, Rochelle, I agree with you, because actually, one of the, I think, key events that's happened, as Simon said, is this concept of cardiometabolic. So that understanding that a patient who has a fatty liver, that could simply be the canary in the coal mine, that this is a patient who would benefit from a more holistic cardiometabolic approach, and go back and think, well, what about the other elements, and then go and find those. Equally, our understanding is that you might have your fatty liver patient living with steatosis in their liver in the hypertension clinic. Maybe their journey starts in the obesity service, your obesity service. And so that understanding, I think, is improving. And as we recognize that, my hope for the future is that the vast majority of people for whom there is the negative predictive value of FIB4, that we recognize that there are pathways available to them, so that whether it's lifestyle intervention, whether it's metabolic optimization, that can happen and be done at pace for those individuals, allowing us to focus the more intensive resources as hepatologists on those with moderate to advanced disease. And I'm sure we're going to come onto it, but some of those interventions that will help individuals with metabolic disease living with obesity may prevent them progressing to those advanced stages of disease. And in those patients with advanced stages of disease, those other interventions may actually help them move in the right direction. So interlinking these services, I think, is going to be imperative as we move forward.
Yes, removing yourselves from those silos. Yes, I'm a hepatologist working in liver disease, but I also need to work with those endocrinologists as well. When our patients present, in these emergency rooms or hospitals or clinics, then if they're presenting with obesity, then let's test them for liver diseases. So I think that's vital. That's very important. So hopefully that's what is happening in the clinical settings.
I think, Will, you mentioned something else there that's really relevant in this setting. And that is, although we're very excited about the availability of drugs and so on to start to treat this, is that package of lifestyle change that needs to accompany it. I think, I'm seeing a lot of nodded heads here, so I haven't said anything stupid, which is good. But we now are facing this additional challenge. It's not sufficient to simply look for a pharmacological solution. It is an absolute huge advantage, and it's something we need to build on. But it is those additional lifestyle changes in terms of dietary interventions, in terms of, and I prefer to use the word activity rather than exercise, because it's not about, lycra and how fast you can run. It's about other things, simply what you're doing in the day, whether you're going for a walk, those sort of additional activities. And I think that's a really important area that we need to package, particularly when we also realize that very effective medicines like GLP-1s, for example, there is always that concern about sarcopenia. And so we need to make sure that it is part of that holistic package.
And the most interesting thing, I think, in the last two conferences, AASLD and the EASL, that we have heard the new concept. And it has been there. We have been discussing it, I think, but it was presented at the forums at this level, which is like, community hepatology or the preventive hepatology, or like, personalized hepatology. And they're thinking like, it should be a part of like one of the specialities, because definitely, hepatology is such a wide thing. And with the 90% of the liver diseases being preventable, this has just opened, I think MESL was the disease which has just opened up this discussion again regarding the community hepatology, which is interesting.
Yeah. So what about policy? Is anybody dealing with global policies and advocacy, or any efforts around global fatty liver disease care? Is anybody dealing with any policies or see the needs for the policies?
So I think as an obesity medicine doctor, I see that obesity and treating obesity first is really at the forefront of treating all of these cardiometabolic diseases, right? But I think the hardest part is, one, the education that obesity is a chronic disease that requires a multidisciplinary team and a really comprehensive approach that includes lifestyle, but also potentially pharmacotherapy. And I think that really that has been lacking from a lot of, at least in America, a lot of our resources and focus for the treatment of really obesity as a disease. And I think the hard part is that, we tell often patients, if you lose, 5 to 10% of your total body weight, you'll have improvements in your MASL, but we're not giving them really structured advice and comprehensive care to really reach that. And so typically I find patients that are like, I'm still back to my own thing of trying to lose weight on my own and having really no structure or plan. And I think that's been really hard because insurance coverage, if you don't have diabetes for kind of a comprehensive lifestyle program, at least in America, has been limited. And so there are policies in place for like the Treat and Reduce Obesity Act to truly push intensive behavioral therapies and coverage to then allow for these multitude of services. But I think the other thing is setting up realistic expectations for patients as well. I think we oftentimes counsel people that, you just got to go lose weight. And that seems so easy. And it's, you can do it on your own, but it's not as easy as, eating less and exercising more or doing more physical activity. And I think, even with the most intensive lifestyle modification programs like the Look Ahead trial, only 37% of people were able to sustain 10% clinically significant weight loss at about 8 years. And so the majority of people are trying on their own as our metabolic adaptation is kind of fighting back against us to drive us back towards weight gain. So I think we need, a comprehensive approach of offering these services, but then also, not letting people get stuck in the lifestyle route without kind of moving them along and progressing them in terms of other pharmacotherapy options or surgical interventions that exist.
And the challenge there, though, just to pick up on what you just said, the challenge there is that you're convincing payers, and it doesn't matter what system you're in, trying to convince payers that they're going to see the return on that investment either within the financial cycle of a year or two, or where I practice, in a governmental cycle, in an electoral cycle. And I think those can be difficult to articulate. I mean, I think there are arguments that we can make. And one of the challenges I would put to ourselves as specialists in this space is, whose job is it to advocate the most for those policy changes, whether it's policy changes in democratizing access to lifestyle interventions, or whether it's about policy change that means you don't put chicken and chip shops outside high schools that only sell discounted stuff between 3 and 4 in the afternoon, that kind of stuff. We've always thought that's somebody else's job. And, the public health physicians would look to us to give them the more specialist input. But of course, this is a diabetes problem, but isn't this a primary care problem? And altogether, shouldn't we really be? So I think we've got to decide that the hot potato needs to sit with someone first, and then we build on that. Now, organizations are starting to pick up on this. The idea of non-communicable diseases as a priority is definitely hitting the agenda. We've got some really strong vocal advocates, certainly within hepatology. I can know for a fact within obesity medicine, in diabetes. So perhaps the momentum is there. But I think we might have to break out of our it's somebody else's problem to crack this nut.
I mean, I think this is really an everyone's problem, right? I think that you'd be hard pressed to find any provider in any specialty that isn't seeing some sort of cardiometabolic complication from obesity that is just, rates of increasing worldwide. And so I think it's an everyone problem. And I think we all need to be raising our hands and talking about and advocating for change systemically and structurally within our own environments, but then also at the individual level in terms of insurance access, coverage, care. I think it's really a global response.
And I will just add, I think it's the guidelines and the policymaker, as the question was, that there has to be more done about that. And I think for the first time now, there were some talks and some discussions ongoing actually last week where, in the parliament, they were talking about preventive and lifestyle medicine. First time in the NHS, we never used to hear this before. And now with the hepatology and all the things that we know that it can prevent, I think previously in the guidelines, it was if the patient was obese, you see them after 2 years and tell them to lose weight. Now it has changed. And the first time in the last year, the guidelines, it gave structured approach of how to guide the patients with the diet, about all the rest of the things. And it was quite elaborate, the things that can be done. So that has been a massive change since 2016 and 2024. I think in 8 years, that's, I think, a massive leap in how the guidelines have changed.
Yeah, and I don't know if you guys are aware or not, but the ADA put out guidance for obesity just last week. So that's something to take in consideration as well. If you haven't seen those guidelines, those are now out. So Dr. Al-Zawi, you mentioned children. So the question I have is, are we seeing improvement in diagnosing and managing fatty liver disease in children? And what challenges remain?
Yeah, so let me preface this by saying I'm not a pediatrician. I think sort of at a macro level, we are seeing very high rates of children living with obesity. I was looking at data this morning from children in what we call reception year. So I think that's 4-year-olds. Every system is a bit different. Or our educational year 6, that's 10 and 11-year-olds. And, somewhere between 30 and 40%, depending on which borough in the UK you're in, have got are living with obesity. Now, that is a health issue across the piece. We've got complications of excess weight clinics being set up across the country, and I'm sure elsewhere as well. We're even talking about the use of medical interventions, surgical interventions in people of young adolescent ages. And so I think we are facing a medicalization of a population, a cohort of our population, saddling them with medical burden from a very, very young age. So even before you think about the pathophysiological consequences, you're turning a whole cohort of kids into patients at a much earlier age. So I think we are seeing more of that. What I'm personally seeing is older kids transitioning into adult care. And we all have, I'm sure, children who were in their sort of 14, 15, coming into our services, and they've already got steatohepatitis, they've already got fibrosis. Now, if you think about the trajectory of this disease, as slow as it may be progressing, a child who's acquired or accumulated that much liver injury is likely to run into trouble fairly soon. And so I think that goes back to the immediacy of needing to put changes in place. In terms of medical therapies, though, these children do have significant health problems. Some of them do anyway. And so we do need to build our services around them so that we can help them and hopefully even claw back some of that healthy living that's there. But yes, it is a problem. And where I'm seeing the net effects of it, of course, what I'm seeing is 4 or 5 years down the line, my pediatric colleagues are seeing it closer to the coalface.
Yeah. What about you, Dr. Honore, Dr. Felix? Are you seeing it in the Caribbean?
Sadly, it remains underdiagnosed. There's an increase of childhood obesity and sedentary lifestyles, and we're beginning to see this more in the early teens. However, screening and diagnostic guidelines in terms of pediatric care in our region is still not well integrated. So that's definitely posing a problem for us here in the Caribbean.
And can I just add one more thing, that there's a lot of children, and I was at a regenerative medicine conference, and the percentage of learning disabilities and autism has increased or doubled or tripled in the last 10 years. So all those children, and when we see them in the transition clinic, which is 17 to 19 years, these are the people with learning disabilities which have actually eating disorders. So they come with obesity, and now we are seeing a lot of them with liver fibrosis as well. So that's another thing, that if there's going to be increase in those issues, that will obviously increase the fatty liver disease and MASLD and all that related consequences.
Yeah, one of the complications is that the majority of work for non-invasive diagnostics has been done in adults. So, for example, there's very good data that the FIB4 score is not particularly performant in individuals under the age of about 35. So, that is a further challenge here, is how one assesses and accurately triages, particularly the pediatric population. There is some emergent literature, but I suspect it's going to lag quite a way behind the adult literature whilst we develop more experience in that area. But it's a great topic of research.
It is, and I think that's a really important point about lagging behind, because the confidence that we've had in the adult population has been because the non-invasives have tracked to outcome. And so we can trust that, we may not be able to exactly predict what would be on the liver biopsy, but at least we can put people into strata as to how they're going to perform in the future. And now we've got data from serial. Now that takes 8-9 years in adults, that median follow-up time for most of those studies. And so that's where we need to be when it comes to the children as well.
Absolutely. I agree with that, especially the research end of it. Most of the research is done in the adults. So what are some of the biggest gaps in research that need urgent attention? What are some other gaps are you identifying or seeing?
Can I just start? So I think there's a lot of ethnic disparities and a lot of, I think that's a major problem that we see in Southeast London, especially, the area that we work. And we have done a lot of community projects. And again, there was just one project that we have finished, and it was based on the FibroScan data of around 25,000 individuals screened locally. And I think it was the different ethnic groups which were very, very less presented, but they had the highest degree of liver fibrosis. So this means that, although there's high fibrosis, but these are the people who were actually not followed up in the tertiary hospital as well. And there was less referrals as well. So I think the major issue in research is that we have a data, but it's just targeted at a certain population. So I think it's the unawareness and the ethnic disparity is one of the major issues.
No, I think that's a good point. I think you can look at research needs right across the spectrum. So if you take a step back, I think there are sort of some really interesting gaps in our knowledge, particularly related to the interaction between our environment and the intrinsic physiology of ourselves. So, for example, endocrine disrupting chemicals, these forever chemicals that are so prevalent in the environment, we still don't really understand fully how they link through to disease pathogenesis and so on. And I think that's an important piece because, of course, public health implications and so on. But you can then move forward from that. We're getting a better understanding of the transcriptomics, the proteomics, etc., of the liver. But we're still early on in our understanding of the metagenomics, in other words, the bugs that live in our gut and how they, again, influence the pathophysiology. And it's going to be the ability to put these together into a multidimensional digital twin and really understand the pathways that are going to be essential to get into that pathophysiology. I think after that, you then move around to slightly more clinically focused questions in terms, and exactly as Simon's just been alluding to there, where are the socioeconomic disparities? They're really important in terms of both identifying patients and then also tailoring the treatment to those individuals. So I think that's an important piece of work. Then there's the diagnostics, and we can talk about that a little bit more. And finally, there's the therapeutics. And right now, although it's I started off by saying how optimistic I am about the therapeutic space, I think the reality is that the pipeline is very, very strong. But at the moment, we're still following a one-size-fits-all approach. We're going to try this drug and hope it all gets better, and then we're surprised or pleased that we see maybe 50% improvement or less with a drug. And of course, I think one of the really interesting things that we're probably going to see in the next 5 years is the idea that you're tailoring the right mechanism of action to the right patient at the right time. And it's that personalization of therapy that I think is going to be really crucial to dealing with what is effectively an incredibly heterogeneous disease like MASLD.
Yeah. Specialized medicine, really gearing your medications to the patient. So, and so what are some other areas, some other ideas for addressing the disparities in access to care and treatment and research and all that? What are some ways we can get around that? What can we do to address that?
Oh, go ahead.
I would say to start with education and advocacy. If we train more clinicians on liver health and we integrate fatty liver assessments into our routine metabolic checkups, I think we would be further. I also think if the universal healthcare coverage schemes, if they are expanded to include liver diagnostics and lifestyle support services, then it would be more accessible for the general population, in the Caribbean in particular.
Yeah, I would echo that. I think education, one for providers, but also the population as a whole is key. But I think finding ways, as primary care physicians are getting, told that they are kind of, the gatekeepers for everything now, including obesity, which is multifaceted and very comprehensive, treatment modalities and approach. I think they need more support. We need more clinical decision support tools integrated into electronic medical records that are kind of calculating FIB-4s on people when they're doing labs, and then automatically kind of raising awareness to the primary care doctor that they might not even be thinking about, that they should be considering, cardiovascular disease, potentially starting a statin. They should be considering referring for illegal liver the liver fiber dense scans and so forth to further triage. I think they're just so overwhelmed with all of this information that sometimes putting, strategies in place within the electronic medical record system would be a good way to help support them. But then I also think if you could eventually expand point of care ultrasound to do the elastography in clinic to help kind of further triage if you don't have resources available in a rural space, et cetera, that would be really important as well.
Yeah. And that addresses the access to care point too, when you're looking at some of those rural communities or those communities that don't have access to a lot of these equipments as well. So I'm sorry, Dr. El-Azawi, go ahead.
No, all I was going to say was I think this is really important to see how the space is evolving. So in response to your question, we've covered, basic science, transcriptomics and genetics, and pathway development. And I think it's important to emphasize that the advancement of the care of a particular condition is a spiral. And so on the one hand, you do need to have the infrastructure in place. There's no point setting up medicines if there's absolutely no infrastructure to identify patients who are going to benefit from them. Otherwise, the medicines will just stay in the cupboard. And so, but on the back of that infrastructure that is set up, which can continue to be refined and continue to be improved, all the work that Quentin described and that lots of our laboratories on this call are involved in is able to then feed forwards into that. There sometimes is a temptation that once a drug starts to emerge, the conferences focus on the medicines, the press releases all focus on the medicines, and there's a sense that it's done. We are far from done. And I think it's really important to realize that, this is a disease that is changing. The natural history, the epidemiology of it is changing during our professional careers. And so it's really necessary to visualize that spiral of improvement throughout the, if you like, the arc of this disease.
Yeah. So let me ask Dr. Noureddin, what do you see as the role of improvement in diagnosing and managing fatty liver diseases in society as a whole? What changes are you seeing? What are you seeing in your work?
That's a whole open question. I think, let me start with what I'm happy with. I'm happy with that the guidelines, for instance, now emphasize on screening the at-risk population, something that the Americans came a little bit later than the Europeans, but I'm glad we caught up to that, starting with FIB4, followed by transient elastography and tests like ELF. And we have seen an explosion of other tests, such as scores to optimize efficiency of these diagnoses, getting them precise, getting them better. But if you actually look at the big picture, I think we still have a little bit bottleneck between transient elastography machines not available everywhere, and the price is an issue there. In addition, having probably only one blood test that is FDA approved, and others are trickling out there. So although we have seen a lot of publications and many tests, I think implementing those is very important. Trying to make their way to the market, cut the price, and importantly also to have more data. It's not just what publication and the test is done, rather continue to have more and more data in different populations, other ethnicities, as well as connecting them to outcomes. So although we have seen a lot of work, some of it came from Will as well as Quentin and others, I think we can continue. Arguably, we can continue on those and make sure they make it to the patient's hands in a confirmatory as well as affordable way.
I think one of the things I wanted to echo that was mentioned earlier is medications are just a piece of the puzzle. And if we don't have the other infrastructure in place, we're not going to be as successful. I think that becomes even more so important when you are using medications, because if you're not providing the appropriate guidance on how to potentially eat, how to be, emphasizing and prioritizing protein or targeting muscle function and improving resistance training, well, then you're going to worsen and potentially cause sarcopenia, which could be worsening the underlying, liver process. And so I think, again, really, and I think we've all kind of chimed in and echoed this, that the approach for a multidisciplinary approach and team is really important, because it's not just one or the other, and you're not going to be successful if you just have one piece of the puzzle.
And then the patient voices. So patients have to be involved in all this, and they should be involved in the policy as well as the care pathways. And they have really helped in the development of the clinical trials and the delivery of the clinical trials. And I think the next process and the next steps that we are taking is when we are having implementation of these drugs coming in practice and prevention strategies. I think we do require the patients along the journey.
For sure.
Yeah. And advocacy, really, really empowering our patients. They're coming to us, for treatment and for advice, but let's empower them too. Let's educate them, and, let's not just prescribe and give out, medications. Let's tell them what they're taking and why they're taking it. Let's direct them to resources that could benefit them. So with
I think on that, again, we're not coming up with anything that's brand new, and I think we should gain a bit of confidence from colleagues that have done this before. So it was 15 years ago that the diabetologists were encouraging their patients to ask their primary care providers for their HbA1c. Know your numbers was the campaign. Know your HbA1c. It's not unreasonable to say and yes, of course, there's a increased pressure, there's an increased workload, but pretty quickly, I think most colleagues recognize that that's a good thing. So for patients to say, what is my HbA1c? How good is my control? Tell me how I'm doing. Is it time to encourage patients to ask for their FIB4 score, for example, if they're at risk? Is that the message that should be given? And so I think we're standing on the shoulders of others who've done this before. So let's borrow from other specialties.
And I don't mean to make it sound like cliche, but let's not forget about the role of weight loss and exercise and replace it with a pill and injection. It's the new medication is approved along with weight loss and exercise. I think it's our duty as physicians to emphasize to the patient, hey, just don't take the pill and forget about what matter most, which is what you're eating and your exercise, and make sure your weight is not going up. Make sure you're not having a big burger every day. Make sure you're not having a soda every day. I think this should stays in the core of the management.
I think one of the things that's needed in that realm, though, is more provider education. So at least in America, obesity education or even about lifestyle and nutrition is really limited in medical school and even in graduate medical education. And so, patients come to doctors thinking that we know the most, when in fact we've probably been trained the least about in nutrition and lifestyle medicine. And so I think that hopefully, there are advances coming and then there's more education in that realm. But I think that we also need to utilize our resources of having registered dietitians, exercise physiologists, behavioral psychologists to kind of help manage everything, because it can't just be on the one primary care doctor who is being told to see more patients and do more with limited time and limited resources. And we really need a holistic team to support them.
Yeah, comprehensive care, absolutely very important. So let me ask you all, what about AI? Where do you see AI? Does anybody use it, see it, or see the advantage or disadvantage of it when it comes to liver disease, managing fatty liver disease? What are your ideas or thoughts?
So there's been some nice work coming out. It again comes to that patient acquisition information. Mm-hmm. So a large part of what a physician does is assimilate disparate pieces of information, identify patterns with them, and match those to either a disease or a likely outcome. And what we're seeing increasingly is the ability to leverage AI to go through electronic medical records, identify those patterns either through linguistic processing or by picking up on certain diagnostic codes or blood test results, for example, or imaging results, pulling those together and coming up with a summation. And I think that's quite interesting. I mean, we were talking about the idea of having, FIB4 automated in the electronic medical record. How much more powerful it would be if in a few years' time we're able to trawl medical records of a whole healthcare system and provide a risk stratification for those individuals most likely to have MASLD, those most likely to have steatohepatitis, and those most likely to have fibrosis, so that we can really focus down. Now, that's a little bit science fiction at the moment, I have to say, but we're beginning to see early data as proof of principle for how that can be done, and we're seeing studies training using registry data, for example, where you take what's called deep data, where it's very well phenotyped, and compare it to shallow data, where you have a larger cohort but slightly less information. And I think we're going to see more on that. Of course, there are other areas, but that's one that I think quite excites me for sure.
And I think along with the clinical data, there has been a lot of research now done on metabolomics and proteomics using AI, which is really helping in developing all these markers. And this process has already been ongoing, I think, for the last 3-4 years. And now we are seeing all those results coming out. So I think that's AI definitely has a part, not only in clinical settings, I think in research and in development as well.
I think given the fact that there's lots of limited support in terms of the comprehensive lifestyle care, registered dietitians, exercise physiologists, clinical psychologists, there's lots of AI-generated tools that can help kind of patients along with the lifestyle interventions that they need to be making to make that, sustainable behavior change. And I think going back to Quinton's point, wouldn't it be interesting if, we have HEDIS metrics to determine if you've gotten your A1C checked every year if you have diabetes, if you are meeting any of the potential criteria to be, fit into the MASLD category, obesity, any of the cardiovascular risk factors, would you now have to calculate a FIB4? And is that occurring? Because I think as primary care doctors, they're probably getting, the comprehensive metabolic panel and getting the liver enzymes, but I think oftentimes they're not recognizing that you need the platelets. And so, how do we help them move in that direction would be helpful.
I mean, the sad fact is that our patients expect this is happening already. How many times have you been asked, well, you've taken my bloods, don't you know my blood group? There is an expectation that comprehensive assessment is done and that comprehensive integration of data is already taking place, such that, the understanding that things are very disparate, that they might not all be integrated, would be quite unsettling for a lot of patients, I think. And at the moment, we rely on our own individual hospital systems, our own personal approaches to ensure that we've thought about all of these things. And I think the medical profession has, to an extent, been slightly resistant to this idea that something could help them along. But I don't think we should. And if I take us back to the last century when I was training, and I won't age anyone else on the call by suggesting they know what this was about as well, but it used to be that the radiographer, when they did an X-ray, would put a little red spot on the X-ray to alert the referring physician that there was an abnormality on there. They wouldn't say what the diagnosis was, but there'd be a little red dot. When we moved to digital imaging and X-rays were taken on images, they thought, well, hang on, what are we going to do about this? So the radiographer would type red dot, the words RED space DOT on the image. So from the very simple, from the very banal, doctors and the medical profession have relied on adjuncts to identify those individuals who might need more attention than others. And it seems to me that whether you have a red sticker on a film, or you have a complex neural network that can trawl through hundreds of thousands of data points, we should be embracing that adjunct to help us deliver that best care to our patients.
Wow, this has been an awesome speak that we're having here, conversation that we're having. So as we kind of close up a little bit, I want to give each of you an opportunity just to give us some takeaways, on liver disease treating, prevention. Speak to us. Let us know how you feel.
I can jump. 2025 for me is a very exciting year. We do have first drug for MASH. We have more coming. We have data that cirrhosis can be improved. We have guidelines. We have patients' awareness improving, not there yet. So I'm really excited about what's coming in the pipeline in terms of diagnostic, therapeutics, and helping our patients. We need to get to disease cure. And I think genetics, precision medicine, diet, exercise, combination therapy will play a role. And I cannot wait for that day. The faster it is, the better. And hopefully our patients will rest assured that we got to handle this disease well.
The last thing I'd add is that fatty liver disease is not a liver issue alone. If we can get everyone to be on the same page and know that it's a metabolic, it's social, it's an economic issue, and in under-resourced regions like in the Caribbean, I believe we must push for integrated, accessible care that addresses the full spectrum of chronic disease, and that screening must become routine. Lifestyle change, it must be a culturally tailored and supported. And then my call to action would be, don't wait for the symptoms, to screen early, to treat holistically, and advocate for access. And I would really love for the stakeholders to train more primary care providers and nurses more on MASLD algorithms, for more subsidies or partnerships in order to improve access to imaging, which is very costly over here on my side of the world, for there to be more promotion of public awareness about metabolic roots of liver disease, and lastly, for embedded liver screening in diabetes and all chronic disease clinics.
I think as the obesity medicine doc, I have to echo some of the things you said. As you know, I think really the crux of all this is if we treat and teach people to treat obesity first and look at kind of the comprehensive approach to all of these things and how obesity touches all of these cardiometabolic risk factors, including MSLD, I think that is the most important part. And the thing is, obesity medicine doctors can't do it alone because there's not enough of us. And so, at least in America, that number of board certified obesity medicine docs is growing every single year, but finding more and more ways for people to learn, to be educated in medical school, in graduate medical education, for really subspecialists to also feel like they are motivated to take, to take the lead and potentially start some of these modalities and talk to them about it. Because if we rely on primary care to solve and treat all of this, we're going to be waiting a long time, because this is just a vast issue affecting so many people. And it's really, from my perspective, an all hands on deck. Every provider needs to be talking about this, discussing it, taking a comprehensive approach with all of their patients.
I think I will just add on what, like, everyone has said, but it has to be, preventive medicine. It has to be personalized medicine, as we have heard in this conversation, but also looking at different ethnic disparities. And I think the most important thing is that there's a disconnect. So in research, in medicine, that everything is coming, I think it should be more collaborative, and how we can aid to the patient's benefits. It's like whatever the non-invasive diagnostic markers we are using, there shouldn't be a competition. There should be like what works better in different situations, different circumstances, different countries. So it has to be a global approach, not like, targeted in one state or one country or one city. So I think the attitudes have to change.
I think like colleagues, I also look ahead with sort of a buoyant feeling. I think we have the attention of colleagues. We have got public opinion. I think from our patients, certainly patient opinion is demanding change. And I think what our responsibility now moving forwards is to make sure that we push on the research front, that we highlight to funders the importance of understanding basic mechanisms of disease, translational aspects like Quentin identified, as well as health service delivery, and that there is a lot more work to be done. I think we have got starting to get the ear of certain policymakers. I think maybe it's the eye-watering bill that they may be faced with that's making them want to come and talk to patients and providers. But now is the time to press ahead. And if we put the patient at the heart of what we do and let the patient drive our research agenda, our policymaking agenda, our clinical change agenda, I don't think we'll go far wrong. But I think it's a buoyant time ahead and a fun place to be.
I think Will has said it all, as have the others. I'm going to just agree with them. I think the big thing we've got to make sure is that we put ourselves in a place where we're able to provide access to medications for our patients. That's a process. It's also a pricing issue. And finally, to make sure that there's that wraparound support in terms of lifestyle change that needs to go hand in hand with everything else.
This has been great. I heard some important things coming out, everybody here, from holistic care to comprehensive care to patient care and education, provider education, screening early, a lot on research and policy. But one of the most important things I heard was patients are at the heart of everything that we do. I want to thank this panel, and I look forward to seeing and working with all of you in the near future. Thank you.
Thank you.
Thank you.